Okay, this video is called How to Read a Brain MRI. I'm board certified in 3 fields. One of my fields is neuroradiology, and I look at these things every day, so I just want to share with you. This is going to be really simple, like 5-minute lecture, and just stuff that you need to know to make sense out of a brain MRI. The first point is you should have heard of what is called a T1 and a T2 sequence. In MRI, if MRI were zoology, in zoology you have animal kingdom and plant kingdom. Well, that's what T1 and T2 is in MRI. Everything is derived from this. On T1, fluid is dark. This is the fluid in the cerebral ventricles. Fluid is dark. Cerebrospinal fluid in the sulci is dark. Okay, on T2, fluid is bright. The word for bright in MRI is hyperintense. The word for dark is hypointense. So on T2, fluid is bright. One way you can remember it, think of the 2 as looking like the letter B if you flip it around backwards, and B for bright, okay? You need to know that for T2. All right, well then when we look for pathology, the secret of seeing disease, pathology means disease, on a brain MRI is you want to increase the signal of the pathology and suppress the signal of the background. So the perfect sequence for that in the brain is called FLAIR. And all you need to know about FLAIR is that it's a derivative, a subtype of T2 sequences. And the pathology is going to be bright. Like here's a FLAIR image, and you can see the pathology stuff is hyperintense. It's bright. But the cerebral spinal fluid, the fluid, is dark. Okay, so there's techniques on MRI where you can suppress things. So we suppress the sequence of the fluid so that we can see pathology adjacent to the ventricle better. Here is a subcortical lesion, and we can see this better on this FLAIR sequence than we would if a T2 sequence because the CSF adjacent is suppressed. If you've got bright fluid, a lesion next to the ventricles, for example, would be suppressed by the ventricular signal in the sense that it would be like squinting into the sun. So this is a fantastic sequence. For all neuroradiologists, this is their favorite sequence. It's called FLAIR. If you were stranded on a desert island and you could only have one MRI sequence, you would want FLAIR. Okay, because it suppresses the CSF, but it still has T2 properties whereby pathology is hyperintense. It's bright. Okay, so here is a coronal image. By the way, these are called axial images or transverse slices through the brain. This is called coronal, front to back slices through the brain. And this is called sagittal, side to side slices through the brain. Okay, so this is a typical pathology on FLAIR. You know, this is juxta. Juxta means yoke to, in contact with, juxtaventricular hyperintensity. This is near the ventricle, so this would be, well actually here's one near the ventricle at the level of the ventricle, so that would be called periventricular, okay? I'll come to this level, by the way, at the level of the ventricles is called the corona radiata level. Below these lateral ventricles down here, this is called the basal ganglia level because these are basal ganglia. Above the ventricles is called the centrum semiovale because it's shaped like an oval when you're at that height, the brain. And it's semi-oval and it's in the center of the brain. Anyways, this is a T1. You can tell it's T1 because the fluid is dark. Okay, that's the most important thing in all of the brain MRI. Fluid is dark on T1, fluid is bright in T2, and then you have subtypes of these sequences. This is a FLAIR subtype of T2 with suppression of the fluid, of the CSF, cerebrospinal fluid. Okay, the only difference between a brain MRI and a man and a woman is that a premenopausal female will have a big pituitary. The top of her pituitary will be convex on its upper margin because of their menstrual cycle, okay? Other than that, male and female brains look the same, okay? Somebody might write a paper claiming some subtle difference, but in terms of looking at them, and I've seen hundreds of thousands of them, that's the only thing that jumps out at you. Okay, and typical guys got a smaller pituitary, and it don't change from day to day. And that's also why guy's personality doesn't change as much from day to day versus a woman on her menstrual cycle. Every guy knows that's, had a girlfriend or a wife. Sometimes she's in a good mood, sometimes she's in a bad mood. Okay, anyways, let's go to the next slide. Okay, now this is a set of image. This is an image, an axial image, transverse image at the level of the lateral ventricles. So this is called the corona radiata in here. Okay, this is above the ventricles. You're in the center here, and it's shaped like an oval. So this is called centrum semiovale at this level. The reason why this terminology is useful for a neuroradiologist is you have to describe where abnormalities are located, and so you need to know the vocabulary. But for the purposes of somebody just watching this who wants the general idea, what you need to know is all the bright spots those are strokes, okay? These are called silent strokes. On the macro for dictating a brain MRI, these are typically called periventricular flare hyperintensities. They used to call them UBOs when they first saw them, unidentified bright spots, okay, when MRI first came out in the 1990s, early 1990s. All right, these are all silent strokes, and I'm going to give a separate lecture where I talk about what causes these. I think the main cause of these is atherosclerosis and overtreated hypertension. Okay, things that cause cerebral hypoperfusion, lack of blood flow to the brain. And again, this is just one patient. How many strokes is this? It depends how you count it. You could count this as 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. At least 16. You could count that probably as many as about 35 if you were more fussy about what's a stroke versus what's a separate lesion, okay? But anyways, that's the point I want to make. You see tons of these, tons of them. One patient can have hundreds of them. All right, here's another patient, and these would be, deep white matter, centrum seminal valley. How many are right here? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. At least 13 little silent strokes there, 14. And by the way, I'll see, 1,000 of these silent strokes for every, significant brain hemorrhage in general. Again, it's a question of how you count them, but in general, that's true. Here's about a cerebral acute infarct. So the main sequence for seeing a cerebral acute infarct is DWI. DWI is diffusion-weighted imaging, okay? ADC is just a counterbalance check for DWI to tell you how acute it is, how recent it is. DWI becomes positive immediately after a stroke. Infarct is the medical word for stroke. And then ADC has low signal, hypointensity. And when you have hypointensity from ADC, that's called diffusion restriction. What diffusion restriction is about is that initially what happens is lack of energy due to lack of oxygen delivery means you can't maintain the sodium potassium pumps in the plasma membrane, and you become hyperosmolar intracellular. You get a fluid shift into the cells. Not a change in total fluid, but a shift into the cells. And that shift is that fluid is initially restricted by the plasma membrane, which initially is intact. So it has a limit in the random motion of the particles, meaning a decrease in random Brownian motion, such that diffusion, meaning movement, is restricted. Okay, and the ADC confirms that it happened less than 1 week ago. Now here's a flare sequence for the same patient that's also positive. The relevance being flare doesn't become positive until 6 hours. So if flare is also positive, that means the infarct occurred more than 6 hours ago. The fact that this still restricts means it occurred less than 1 week ago. And that's how you can time an infarct. ADC will neutralize the background after 1 week. So if this is still positive, this typically DWI stays positive for 2 weeks to, think of it as being about 2 weeks to 2 months. Okay. And so the way I would remember this is A for ADC. A is the first letter of the alphabet, so I remember A for 1 week. This stays abnormal 1 week. I remember D for dose, letter number 2 in Spanish, and so D for dose meaning it stays positive for 2 weeks to 2 months. Okay, that's how you think of things. So you can time all these infarcts, and that's what I tell young doctors when I'm training them. Okay. All right, here's the SWI sequence, susceptibility weighted imaging. On susceptibility weighted imaging, they obtain the images real fast, and they don't do anything to minimize artifacts. So in a magnetic field, if you have a bleed, the blood has heme in it, which has iron in it, which has a little bit of a local magnetic field around itself. And that'll cause a distortion of the MRI image. Normally, other sequences have correcting gradients that will sort of remove them, and they'll perceive them as being an artifact. But the SWI, susceptibility weighted image, is actually called a magnetic susceptibility artifact, is what you get from heme, from the iron in blood. So these are all little intracranial bleeds. And what I'm going to tell you right now is actually a rather profound statement, so this is worth listening to. I know some of this was just jargon that you really didn't care about, but here's something that you're going to care about. With hypertension, you typically get the bleeds, the microbleeds, centrally. So really high pressure causes these little microbleeds centrally. Now, these peripheral microbleeds are thought more often due to a type of dementia called cerebral amyloid angiopathy, which is thought to occur in association with with Alzheimer's disease. But the reason why I think that's a bit of a joke is because I look at these all the time. I've seen thousands of cases like this. And I routinely see both present in the same patient, central bleeds and peripheral bleeds. So is it due to hypertension, or is it due to amyloid angiopathy, and Alzheimer's, or are they maybe the same thing? And so what I'm basically saying here is I think they're largely the same thing. Most common cause of those silent strokes and of these microbleeds is hypertension. Okay, I see hypertension patients all the time. Sometimes I'll see them only with peripheral bleeds in young patients in their 40s. And of course, sometimes I'll see them only with central bleeds, but I see them all over the place. And the same patients who get this have increased tendency to get hypertensive hemorrhages in their eyes, hypertensive retinopathy. Now here's a bigger bleed, this big white spot here. This is a CAT scan. In CAT scans, we talk about density because the radiation beam passes through the head. It's like a donut around the brain, and it'll have the beam comes out on one side and the detector's on the other side. These little tiny white spots, those are just incidental basal ganglia calcifications. This is just an incidental calcification in the pineal body. And most of the time, big bleeds present more suddenly. This patient will have a dramatic neurologic deterioration. And so they'll just get a CAT scan. They'll even be too sick to go for an MRI a lot of times. And, it's an obvious hemorrhage there. Okay, we'll sometimes, check to see what's the cause of the hemorrhage. We'll try to figure that out. But the point I'm saying is big bleeds happen suddenly. Go to the CAT scan, and that's usually enough in that setting. Okay, then here's the last slide of the talk. Here is a tumor, glioblastoma multiforme. We often abbreviate them GBMs. And here you've got a loss of the blood-brain barrier, which normally keeps stuff out of the brain parenchyma because of the tumor has eroded through it. This bright stuff here is the uptake of contrast. We look at the post-IV contrast images on a T1 sequence because T1 images in general are kind of bland. There's very little signal in them, so the contrast will then jump out at you because the contrast will be hyper intense. And you can see we're starting to push across the midline here. This is called the falx. We're going to actually be pushing underneath the falx. So this is a subfalcine brain herniation across the midline. And you'll often hear doctors that work in these areas talk about midline shift. How far is this ventricle shifted from where it should be? About over here, about 1 centimeter. So this would be right frontal lobe, ring enhancing mass, about 3 by 4 centimeters in diameter with 1 centimeter of subfalcine midline shift. Okay? All right, so then the question comes up, well, that's a big tumor. Regular person, they shouldn't have a leak in the blood-brain barrier. But the reality is every normal person has some gaps in their blood-brain barrier. These occur at what are called the circumventricular origins. So circum means around the ventricles. Around the ventricles, you have areas of the brain that do not have a blood-brain barrier. And the reason is they have chemical sensors in these areas. For example, area postrema senses if you eat something toxic, and it activates a vomiting response so you can get that out of your body before you ingest more of that toxic chemical. There's other sensors around here that are going to sense, certain hormones in your blood. They're going to sense, other chemicals in your blood that they need to know about, your sodium level, for example. So these areas don't have blood-brain barrier, and toxic chemicals can get into these areas and damage them. Like the pineal body, really important for making melatonin to help us sleep, and it does other good things as well, like it's an antioxidant, for example. So the pineal body is often damaged relatively young in people by toxins, by F- and whatnot. So that's what I'm trying to say is even in the healthiest person, there's areas without a blood-brain barrier. Plus, when a person starts having areas of ischemia, lack of blood supply, diabetes, damage due to trauma, damage due to hypertension, they have more and more areas in wider and wider varieties of the brain where there's no blood-brain barrier. So anyways, this was just an introduction to give you a clue when I talk about brain MRIs, because I want to talk about more advanced brain stuff. And I have to have this intro lecture so that people can get a clue real fast. And the most important thing to know out of this whole lecture is that T1 is dark signal for fluid. T2 is bright signal for fluid. In general, in all of MRIs, as a matter of fact, in every part of the body, what you want to do to diagnose a disease is increase the signal of the disease and decrease the signal of the background on that particular MRI image. So, hope that was helpful.